Thank you very much, everyone. We're at AWE 2026. It's hard to believe we're there. And it's an honor to have Dr. Shah with us today. We've known each other for a long time.
Long time, Sonia.
And every time we meet, we're like, we have to do it. And we're finally doing it. So we're super excited. And we're super excited to talk about, I know yours and my favorite thing to do is to do ERCP. Yes. Cannot be anything better than that,
no,
right?
That's the ultimate.
That's the ultimate satisfaction.
Yep,
you get that stone out.
Yep.
And now there's so many advances how to do that, and you're the expert to tell us what we should be doing better. So please tell us. We're going to be covering today several things: the spike cholangioscopy and disposable duodenoscope, and the new stent that is out. So we have a lot to talk about.
Sure.
What shall we start with?
Why don't we start with the endoscope?
Yeah, let's start that. It's like a natural way to go.
Sure, before we get into the duct and all that. So, so I'm holding here the Exalt Model D endoscope. It's a disposable ERCP scope. As you know, the interest in this really stemmed back 10 plus years ago from infection risks with reusable endoscopes. And that sort of spurred an idea of would it be useful to have disposable?
And then FDA required us to do it.
To do something different. Exactly.
Yes, spur dust over that, right? Yeah. Can't quite say no.
So I think its use, it varies where you go. Some people, I can talk a little bit about our institution.
Please.
We stock these. Our infection control has okayed our process for reprocessing our reusable endoscopes. So we have both. One of the main benefits, though, we found is we will often use these disposable ERCP scopes towards the end of the day. So
Angela, right here.
Our nurses will ask us, especially if we're going to get into the after hours time or weekend cases, we will often use this as our go-to.
1 o'clock in the morning.
Exactly. We have a pediatric ERCPist at our institution. He will also sometimes use this. This is somewhat smaller diameter. And it's my understanding actually that there may be even smaller diameter versions coming out.
That was the little bird was saying.
Yeah,
right?
I've heard that from a little bird as well. So we'll see where that takes us.
Next year we'll discuss it, maybe.
Yeah, exactly.
Yeah, that's right.
And I'll also say we are doing some edge procedures in gastric bypass. And our group does find it also useful. It's given the smaller diameter to facilitate edge procedures to go through a lens.
Do you find if you're in a situation where there's a big J-shaped stomach and there's a little bit of a challenge just getting to the papilla, are those useful in those situations?
Yes, I mean some of my partners I know have switched to that at the time when they a standard endoscope was a little bit of a struggle. But I think our other uses are most common is the after hours and weekend.
That's good.
That's almost I'm often, if I'm on call, my nurse will text me, okay to use the Exalt, and I'm like, yes, absolutely, right? Because they want to get out of there ASAP.
Yeah.
So it's a good use.
All right. And any tricks how you maneuver? Do you feel it's any different that the?
No, it is a little bit more. So I will show you a couple things, and I will pull this out right now. But it is a little bit stiffer of an endoscope. It's also, couple things I will say is that often on the reusable endoscopes, I'm often, when I'm in place, locking my wheels. You don't need to do it as often. It will maintain its position.
Okay.
So one thing I'll say is on the insertion, don't assume it goes back always to its neutral position. You may need to maneuver it a little bit if you encounter resistance. And on the withdrawal, if you're already in an angulated position, make sure to relax the knob back to the neutral straight position. You can use fluoroscopy as well to show that.
I didn't know that.
Yeah, so because you can cause, if it for instance, look, I'm doing the up down this way. I let go. There's still it
doesn't bounce back as much.
Exactly.
Oh, that is a great
So something to think about. The cholangioscope will actually bend in 4 directions here. You have it? Yep. And there is a locking mechanism that provides some
Sorry.
rigidity to the tip. So these are things to keep in mind as you're trying to engage and go up the papilla. If it is tricky, there's no harm in going over the wire, but I just like to show kind of going alongside.
Yeah, I like that. I do it all the time. Then
Yeah.
when you have to take the fragments off,
Yeah.
saves you a little
Yeah.
time there.
Now, one thing I will caution when you're doing this, often we are using a lot of irrigation, especially if we're thinking about doing lithotripsy,
Yes.
electrohydraulic. So ideally, put on some boots. And
That's a nice trick.
it is, yeah, you need, you know,
Some coverage.
some
there.
coverage because the area can get quite wet.
Tell me,
as-
how do you do EHL? Like, on what settings you normally do? How many shots? What is your preference?
I usually keep it in that there's our unit has low, medium, and high
Yes,
pulse rate.
same.
We usually stick to medium just
Yes.
as our with it's a number of pulses per
Yes, exactly, yeah,
exactly.
yeah.
And then if it's particularly not responding, I might
Crank it up.
Exactly. There is a life on these probes, so
Yes.
we know when we have difficult stones, we're sometimes going through even 2 or 3 probes. But you know, usually at that point, it's difficult enough where you take out what fragments you have and you come another
Come back
day
to fight
yeah,
another day,
yeah.
yes.
So I'm gonna insert this in, and the other reason I like to also go alongside, I'll be honest, so here, as I'm anticipating the 2 or 3 centimeter stone you gave me, I don't know
Yeah.
which, but either way it's large.
Good size.
Yeah,
Good size.
I likely would have already put my EHL probe,
Preload, yeah.
preload it down, because it can be a little challenging sometimes to have that probe go up
Of course.
alongside in an angulated
Duct.
angle up the
So
duct.
what are your tricks for that? If
So-
it doesn't come out?
Yeah, so one, if I can get my probe in at the beginning, I leave it at the tip,
And
get
just
in,
go
and
in.
then I'm ready to go. If you had to go over the wire to get up into the duct,
Yeah, then that's more
then it's a little bit more,
Okay.
because it's the same channel for that.
Yes.
Then I'll take the wire out, I will go down, but if I encounter resistance, then I will pull my cholangioscope. If I'm already up high, I'll pull it down a few centimeters, push the EHL probe as far as I can go, and then push my cholangioscope and advance it up into the duct. That usually gets the entire mechanism and whatever's inside up a few centimeters and past that angle.
That sounds great. Let's see the stone.
So here's where I'm using my cholangioscope.
Nice.
I locked it a little slightly, and we'll see if we can get up alongside.
Yeah, you're in.
Yeah. So now we've still got to drive it up.
I see something.
So I use my my large knob here to drive it up. So,
All right.
right.
Here's
And
your
we're gonna
impacted stone. Maybe somewhere.
We'll see.
We lost the stone. We lost
Oh no,
the-
we're getting into some ducts up
So,
here.
yeah.
So, and again, right now we would be irrigating. We have beautiful visualization.
Yes.
Usually we're asked to comment on the quality, and this would be in the excellent category.
Yeah, that sounds great. So let's say we broke the stone and cleared the fragments. And you do have, as I mentioned, the small caliber duct there,
Yep.
and there might be some fragments. Do you ever consider putting a fully covered billetry metal stand to help you facilitate?
Absolutely. So I have a low threshold to think about placing fully covered stents. One thing is when there's multiple fragments, and I know I'm still coming back, I think some of these fragments just pass
Just gonna
on
come
their own.
out, right?
One thing I'd like to show everyone is that
Yes.
there is, I don't know if a lot of people are aware of this, but there is a spyglass cholangioscopy basket.
That's right.
Which is, so if it's really just one stone or small, or I know earlier we
I
have a
love
presentation
those,
on
right?
a fluoro-free ERCP.
Yes.
This would be a very useful way to manage stones, small stones or fragments.
Oh, yes.
So I will
Thank you for reminding us
so
about
let me
that.
show you. This is the
Against the
basket,
hand.
and this is compatible. There's also a snare, but I find these baskets a nice way to remove small
Patients
fragments.
who are pregnant,
Yep. And this just,
or
and I'll show you what it looks like inside. Oh, it's going okay. Thank you.
all right.
So
I
we'll
could have
just-
made this patient pregnant too.
That
For you,
would have increased the level of difficulty.
We could have put it up a notch.
Yep. Here, let me just. I want to be able to show these how this.
But that's, I
Okay.
saw the trick that you did. You kind of advanced the scope in
Yes.
and cleared that
Yeah,
angle,
so
right?
whatever is inside, so I pulled my cholangioscope back a centimeter or two. I pushed my device. Now this again applies whether it's a laser probe, EHL probe, or through the scope basket. And then I can advance the whole scope to get beyond the bend at
Yes.
the papilla. Okay, let's go ahead and open the basket. And you can see
Nice.
it opens beautifully. You see that? It's
Yeah.
in, and this would be easy to capture a stone.
Capture, and we're
Yeah.
done, and we come out.
And you can pull out, exactly.
Yes.
So
But
just wanted to
and
show
we
this.
also, the other thing that we wanted to show is the fully covered, novel fully covered biliary stent has a little dumbbell anti-migration mechanism. It's on a typical Boston Scientific platform, so we're all familiar with that. And for something like that, where you have a lot of fragments, sorry to give you a difficult stone, and it will manage that distal normal size bile duct to help to clear all of that out.
Correct. And we'll also say, I think at our center, we use a lot of the wall flex, even the standard wall
Right.
flex. So my thresholds to use a covered stent to help engage for that removal of the stone fragments is low. Often for large stones, I've done a cut and a dilation.
Yes.
If I have oozing there, I have a low threshold to put this in because I don't have to worry about bleeding.
Oh, that's
all
a great point.
So that's a very low threshold for that I have. And then this particular version, I will say that recently we've started using it. We have a large liver transplant program.
Yes.
So we have found that this can give us a little bit of breathing room and less risk of migration with placing this, especially covering that anastomosis.